So we're going to start off this session giving you a little bit of an overview of the Centre for Childbirth, Women's and Newborn Health. And then we're going to drill down a little bit more into some of the key programmatic areas. So I'm going to start off by telling you a little bit about the vision. So our main vision is to ensure that all women and newborns can access high quality and respectful healthcare wherever they live. And the way we're trying to do this is by delivering cross-cutting and innovative research, using expertise across a range of approaches, and the approaches are from evidence synthesis through to evaluation and implementation. We have strong, sustainable international partnerships with academics, policymakers and clinicians. We also have meaningful involvement of women, families and communities. And capacity strengthening is a key element of all the work that we do, particularly of frontline midwives and nurses, as well as some others. And we also support a thriving network of postgraduate students and early career researchers. Now, maternal, newborn and child health is clearly a cross-cutting theme across the university. But at the beginning of this session, we're really going to focus on three thematic areas. And these are linked by capacity strengthening and also by the applied global health research that is carried out. So I'm going to start by telling you just a little bit about my programme. I only have a very short time, so it is just a very snapshot. But it is about stillbirth and neonatal death. And I just want to acknowledge that this can trigger emotions, particularly for people who have had lived experience. So if people do feel after the session that they need any support or would like to talk, I will be available, and also my colleague, Dr. Tracy Mills, who you see on the picture here and you'll hear from shortly. So just a bit of background to our programme. We know that 1.9 stillbirths and 2.3 million neonatal deaths occur annually. And Sub-Saharan Africa and South Asia carry the heaviest burden of about 75%. I'm sure I don't need to tell you that this is a tragedy for everybody who's involved, the women, the families, and also the health workers as well. And what's really sad is that most of these are preventable with access to high-quality care. So there's a real need to accelerate progress in this area, and this is a real challenge. If you look at the map on the right, these show you the global targets and where the progress is being or not being made at the moment. So there are global targets that no more than 12 stillbirths per 1,000 births and of no more than 12 newborn deaths per 1,000 live births. And the target is set originally for 2030. But you can see from the map in the orange sections that this is unlikely to be achieved by 2030. And in some of the countries that we're currently working, it may not be achieved even in 2050 if we progress at the current rate. So this is a real issue. So we've been leading an NHR Global Health Research Unit on the prevention and management of stillbirth and neonatal death across different countries, which I'll come to shortly. And we have three primary objectives. One is to determine the best way to reduce the number of stillbirths and neonatal deaths in these settings, to determine how best to support women and families who've experienced a stillbirth or neonatal death, and also to develop research capacity and mechanisms of knowledge transfer in these high-burden settings, and again, with particular emphasis on midwives and nurses. These are the settings that we are currently working in. You can see 6 countries from Sub-Saharan Africa and 2 countries from South Asia, all with a high burden of stillbirth and neonatal deaths. Just for reference, the countries that we're working in have almost 10 times the number of stillbirths than we do in the UK. So what are we doing about it? Well, I haven't got time to go in any detail, but these are our programme work streams. So each of these is a research project. And we're covering the whole continuum of care, from antenatal care on the left up to postnatal and bereavement care on the right. We use different methodological approaches. So, for example, we have a qualitative in-depth study looking at adolescents' maternity care experiences, but we also have 2 trials. One, which you see on the left, Panda. This is a mobile phone app which supports antenatal visits with the aim of increasing those visits and reducing perinatal mortality. And this has been conducted in Tanzania, in Manyara, which is a rural area. We also have a large step-wedge study, which is being conducted in India, Pakistan, Kenya, and Uganda. And this is evaluating a bereavement care package. And Tracy Mills will be telling you a little bit about that shortly. We also have a number of feasibility studies, which will lead to larger trials. So a whole mixture of methodological approaches, countries and topic areas that cover the whole continuum of maternal and newborn care. Core to all of these activities is capacity strengthening. We have very strong community engagement and involvement, and we also have stakeholder engagement in all of these programmes. So why are we doing this? Well, obviously we want impact, and we believe that this programme will provide multiple returns on investment and improving outcomes. And the way we're doing this is through robust and novel evidence to underpin improved healthcare practice. We'll be raising awareness amongst professionals, policymakers and communities, challenging stigma and shame, and strengthen the capacity of the local midwife and nurse researchers to direct the future research agenda. So that was just a whistle-stop tour of my programme, and these are our partners. And I'm now going to pass you over to my co-chair, Charles, who's going to tell you a little bit about his programme.
Okay, thank you, everyone. Thank the organizers for giving me the opportunity to speak. So I have probably less than 4 minutes to give an overview about the Emergency Obstetric Care Research Group. So as we know, sadly, in many parts of the world, the risk of death during pregnancy and childbirth is still significantly high. And based on current WHO analysis, we will have to really more than double our efforts if we're going to be able to reduce the annual rate of reduction for this perinatal mortality. We'll have to go up to 5 or even 10 times to be able to make any difference. Now, the WHO has proposed several approaches in terms of improving quality and equity. One of the big problems why we're not able to reduce morbidity, the risk of death during pregnancy and childbirth as fast as we would like it to be, is because of gaps in the access to the quality of care that is provided. And the WHO has proposed, along the continuum of care from antenatal care to postnatal care, and really focusing on social determinants of care to help accelerate progress in reducing these mortality and morbidity. From the last session chaired by Sally, they spoke a lot around the importance of social determinants of health. Some of our work, we just dip our toe into that a bit, but most of our work in the research group touches on the first 4 pillars that you see here. We conduct global applied research, implementation research. So there's a lot of evidence out there, but how do you implement this evidence in specific context to bring about change, is a key issue. I'm not sure where that alarm is coming from. Is it from the... Oh, no, thank you. I thought because I've exceeded the time. So the three areas which we focus on is on capacity strengthening. As Tina has said, if you look at front care workers, people who provide care when women come for pregnancy and childbirth, most of them are nurses, most of them are midwives, and they provide 70-80% of the care required. So it is important that these people understand how to translate evidence into care in every setting. And so one of the key pillars which we work in is capacity strengthening, health system strengthening, and also a lot of work being done around quality of care using a diverse range of research methodologies. So it's just really giving you an overview of what is happening, and I'll probably pick just a few areas and then we will have one of the speakers, Duncan, will go in depth in one of the areas. So in health systems, we've done a lot of work around, packaging evidence in the best way to help policymakers make decisions. For example, the maternal, newborn and child health risk scoring metrics and prioritization tool that we developed with colleagues in Chad and can be used in such settings to see visually, where investments will have to go for maternal and newborn health. Also, things around helping us push the agenda in terms of universal health coverage, so increasing access for care. Lots of political pronunciations have been made around free access to maternal and newborn health care. But in reality, to what extent does it help move families out of poverty? So we're doing a lot of important work around this, in a very big study in South Sudan. When it comes to capacity strengthening, we've developed several packages meant for healthcare workers at different levels of care to complement their existing education and training, and also working, at the level of midwifery training institutions. So Duncan is going to speak about a body of work we've done around midwifery faculty development and how we have helped to move this from research into policy in that pathway to impact. And finally, so a lot of work has been done around quality of care, and I think a lot of exciting work going on with colleagues in the University of Lagos around the use of intravenous iron for the treatment of anemia, implementation research around postpartum anemia, how best to learn from morbidity, near-miss, maternal deaths, and use that to improve the quality of care at the healthcare facilities where this occurs. So these are quite important. We've also developed tools for improving the effectiveness of monitoring patients during intrapartum care, postpartum care, a sort of early warning system that triggers action to prevent any further morbidity or mortality. So we interact a lot with a lot of the priorities set by global partners led by the WHO. And one of the areas that we really contribute to is in terms of health service delivery for quality. So all the health workforce capabilities and competencies, and linking this with other aspects of the healthcare system to bring about change. Now, a lot of our work feeds into global bodies and advocacy groups where we interact to create more research, use the evidence we've created, and listen to people, listen to other researchers, and also advocate for more funding into all of these areas. And one of those groups is the Global Alliance for Improving Midwifery Education. At the WHO, we feed our information into the WHO Maternal and Perinatal Surveillance and Response Group and the WHO Technical Advisory Group for the estimation of maternal deaths. There are lots of people to thank, from postdocs, PhD students, a lot of colleagues working in several universities in the countries where we work. But most importantly, without funding from the partners listed, the funders listed on this slide, it will be impossible to do all the work that is going on at the moment. So this is just quickly giving an overview, not going into any details of any of the projects, but I think we'll have one person from each group, talk in detail about some aspects of our work. So thank you for listening, and I hand over back to Tina. Thank you.
Thanks, Charles. So without further ado, I'm going to invite the next speaker, which is Dr. Tracy Mills. She's a reader in in the Centre for Childbirth, Women's and Newborn Health, and a midwife, and she's going to tell you a little bit more about our programme. Thank you, Tracy.
Thank you very much, Tina. And thank you very much. Thank you. Thank you to the organisers for giving me the opportunity just to share a brief overview of some of the work we've been doing around bereavement care with colleagues in Kenya, Uganda, India and Pakistan. So both Charles and Tina have told you something about the unacceptable toll of stillbirth and neonatal deaths. So a baby is stillborn or dies soon after birth, about every 8 seconds, which is completely unacceptable. And this is amongst one of the most traumatic life experiences for parents. And the impacts of stillbirth go even far beyond the parents to affect their families, communities, and society. So a really, really big issue. So we know that compassionate support in the postnatal period is absolutely vital for parents to adjust to the experience and carry on meaningfully with the rest of their lives. And the drive to increase births within facilities means that health workers play a much more important role than they did long in the past in this. Unfortunately, many parents globally do not receive the support they would wish after the death of their baby, and this aspect of care has been critically neglected, particularly in many low and middle income country settings, amongst all the competing priorities they have to improve maternal and newborn health. So there is a great need for development of context-specific interventions to improve care, and it's very important that the interventions that are developed within the context and with the people who are going to be on the receiving end of these interventions, because of what you've heard earlier about the social, cultural, religious and diversity in these settings. So the aim of this part of our programme is to improve bereavement care in maternity facilities, postnatal and psychological support and outcomes for parents, families and communities. So the initial work was done in Kenya and Uganda, and we have expanded within our global health unit to include India and Pakistan in this work. And all of the work is underpinned by the NIHR MRC framework for the development and evaluation of complex interventions in healthcare. So the starting point was it was very important to understand the context and experiences of bereavement support in these communities. So we did a lot of qualitative work initially to understand both parents and health workers' experiences of bereavement care. So in the studies in Kenya and Uganda, we included about 200 participants in these qualitative studies, and we found some very interesting findings. So the data very much confirmed the significant and profound impacts of stillbirth and neonatal death on the parents, but also on the health workers. So we did have some examples of really good care and support. I think it's important not to be over negative and to celebrate good practice where it exists, but also many parents experience very negative experiences in health facilities. So there was quite a lot of poor communication, lack of information, and limited emotional support. Health workers quite often experienced inadequate preparation and education for this aspect of their role, and certainly organisational support in their organisations was lacking. So these data were used to underpin the development of an improving bereavement support package. So this was done using a systematic process to reach consensus, which involved community engagement and involvement groups and stakeholders in the settings. So the package addressed two main areas, so improving support in facilities and improving support in the community. So for the facility part of the intervention, we developed a staff workshop which was meant to improve the health workers' capacity to provide good bereavement support by understanding the principles. We also created a bereavement champion role. So this was by giving extra education to a smaller group of health workers who were skilled in communication and behaviour change techniques to try and embed some of the good practice changes within the facilities and sustain them over time. We also, to address community support, trained some peer volunteers who previously themselves had experience of stillbirth or neonatal death to provide telephone support to women in the early postnatal period. So this package was feasibility assessed initially to determine acceptability, that we could implement it, and also the potential for a large-scale evaluation. So the study was done in Nairobi and Kampala. We recruited 107 women. It was a pre and post design, and despite the study actually reaching the intervention phase right in the beginning of the COVID pandemic, we managed to recruit 89% of the planned sample, and by some miracle, 85% completed all data collection. So that was fantastic. The implementation was mainly as planned, and the study really demonstrated that the intervention and the research were acceptable to the participants. We've subsequently done studies in India and Pakistan, adapting the package and testing the feasibility, and those have now completed and the analysis is underway. So we've moved on to a larger scale evaluation, and this will evaluate the impacts on clinical outcomes for women 8 to 12 weeks after stillbirth and newborn death in 6 sites in Kenya and Uganda. So in Uganda, we've got sites in the central region, and in Kenya, we have 2 sites in Western Kenya and 1 in Nairobi. So the design for this study is a pragmatic step-wedge cluster randomised controlled trial, and we also have an embedded sub-study which is just evaluating the peer support component with individual randomisation. So in our 6 clusters, we have the clusters are made up of single or multiple maternity facilities with in excess of 10,000 births. And the primary outcome for the trial is a reduction in grief intensity, which we're measuring using a perinatal grief intensity score 8 to 12 weeks after birth. So the sample size is 840 postnatal women who've experienced stillbirth or neonatal death, and the study's powered to detect a 1 standard deviation reduction in the perinatal grief intensity scale with 90% power. So we're also looking at secondary outcomes, including depression, anxiety, perceived social support, and diagnosis of a mental health condition. And we're in parallel studies alongside the trial, we're also conducting process and economic evaluations. So, progress. We started off with a public randomisation to allocate the order at which the intervention would be introduced, as it's a step-wedge trial. You can see the step-wedge design on the schematic there. And we used a minimisation approach for balance in the randomisation. Recruitment opened in March 2024. And as you can see, the clusters cross sequentially from usual care to intervention in 6-week periods. And in the crossover period, so that's the orange, if I can, yeah, is that it? Not very good at controlling these things. So the orange boxes, so that they're the periods where the sites are preparing for intervention. So in clusters C and D, we're conducting the individually randomised study of peer support. So that's the offer of telephone peer support versus usual care in addition to the facility-based interventions. So progress, we're actually doing really well in terms of recruitment. So we've already recruited in excess of 600 of our samples, so that's on target. I think that just illustrates, though it's quite sad, isn't it, that recruitment's actually been easy, much easier than I anticipated. And that just shows you the numbers of stillbirths and neonatal deaths in these sites. And follow-up will complete by May 2025. So, in conclusion, I hope you will agree that parents' adjustment and well-being after the death of the baby is really very dependent on appropriate support. This is not something, we as humans can do on our own. We need those around us to support us. There have been really few large-scale effectiveness evaluations of bereavement care interventions conducted, and that includes high-income countries. So we're doing a lot of things, for instance, in the NHS in terms of bereavement care, which have never been subjected to any kind of effectiveness evaluation. And this might be where some of our work can actually, come back and inform practice in high-income countries. And no effectiveness evaluation has ever been reported in sub-Saharan Africa. So this study will evaluate implementation, impacts of the package on clinical outcomes, costs, importantly, and the potential for future scale-up. So I'd just like to thank all the partners who have been involved in making this very complicated and at times stressful study happen, but it has, and also the funder, NIHR. So thank you very much.
Thanks, Tracy. Such an important study, and just to say it's having huge interest globally, this study, because it's quite unique, both in its design and where it's being conducted as well. So we have got time for one or two questions. So maybe we could take a question from the audience first, if anybody has one. Yes, thank you.
Tracy, sorry if I missed it. What actually are you measuring in this trial? What will be the outcomes? Is it clinical incidence of depression or?
It's grief intensity. Oh, sorry. Well, yeah. So we're actually measuring grief intensity. So it was quite difficult to decide exactly what outcome to measure because nobody's done a trial in this area before. So when we looked at sort of the literature, what the important thing is that it's the intensity and the length of grief. Grief's normal. You would expect people to grieve, and that's a completely normal thing to do. But women particularly, and this extends to their families, who experience this very intense and long-lasting form of grief, are particularly at risk of going on to develop chronic mental health problems and other health issues. So it seemed to us that sort of the most direct thing we could measure was grief intensity. So we have a scale that has been developed. It was developed in the US, but we validated it in both countries and translated it into the local languages in order to use it in the trial.
As a self-reported sort of scale?
Yes, it is. Yeah.
Thank you. Do we have any questions online, Abira? No? Okay. No more questions in the room? Well, if you do have questions, Tracy will be around all day if you want to grab her. So thanks very much, Tracy. That's excellent. So now it gives me great pleasure to introduce our next speaker, which is Dr. Duncan Shikuku. An alumni from LSTM. He did his PhD here, but he's now a midwife specialist working for UNFPA in the headquarters. So welcome, Duncan.
Thank you so much, Prof. Yeah, greetings everyone, and it is a pleasure to be invited by Liverpool. I'm happy to be here to present to you the work that we've done around midwifery education, how this research leads to impact, and I'll be summarizing 5 research studies that we worked on within the next 10 minutes. So as a background, I'm sure each and every one of us here has passed through the hands of a midwife. I'll be very surprised if there is anyone who has never passed through the hands of a midwife here. We all know that at least the greatest care, these people are the majority providers of over 90% of the care within the sexual, reproductive, and maternal newborn health. And they are able to avert over 2/3 of these perinatal mortalities. And despite their huge impact, they only form about 10% of the global health workforce working within this maternal and newborn health space. However, there are also challenges. Global evidence have documented challenges with the quality of midwifery education, particularly in the poor, low-middle-income countries. And these are the countries that have the greatest burden of maternal and newborn mortalities. And most of these challenges revolve around things to do with the curriculum, which is largely theoretical, and also the educators are insufficient and inadequately prepared. Now, the global strategy for health workforce, human resource health workforce 2030, places a lot of emphasis around investing in the quality of educators and also the curriculum for us to be able to have adequately prepared healthcare workers to be able to respond to the emerging needs within the society. But if you have a case where you are having most of our curriculums being theoretical, and yet we understand midwives are practical people, then it gives us a challenge on how our graduates are prepared. And then another challenge is the lack of opportunities for these midwives to be able to update their knowledge and skills so that they can deliver quality teaching to the students. And a lot of also these challenges revolve around the clinical settings where we expect the midwives to be prepared so that they can be better providers. Now, the International Confederation of Midwives emphasizes that midwifery training is a practical training where at least 50% of this training should be practical-based. And you've just seen in the previous slide that most of these teachers are confident in teaching theory and not practical. And WHO also emphasizes that as skilled health personnel, they need to have the skills in emergency obstetrics and newborn care, at least for all the skilled health personnel, to be able to handle the emergencies, which are the greatest contributors of maternal mortality. And to strengthen this midwifery education quality, WHO proposes a 7-step action plan that focuses on seven main areas revolving around things to do with data, advocacy, building educational institutions, strengthening the faculty, standards and curricula, educating students, and then monitoring these interventions to ensure that students are being given the right education to come out as properly trained people, and then strengthening the policy. Now, through the Ministry of Education, the Ministry of Health in Kenya, through the Pre-Service Task Force and Liverpool School of Tropical Medicine, we've been able to implement a number of these steps in Kenya, which I'm going to summarize in the next 5 studies, each of them addressing a specific one. So our first study was a pre-service EMOC training intervention package, which was a quasi-experimental study to measure the effectiveness of this intervention. And the intervention included preparing these teaching institutions by providing the EMOC training equipment, providing training for these educators in the EMOC, and then following these educators at least on a month or 3 monthly basis, monitoring for these educators. For these groups of the study, we had 3 arms of the study: the intervention arm and the control arm. Now, for the control arm, no intervention was provided here. And for the intervention arm, we had 2 groups of the intervention arm where all the intervention groups received all the interventions, as I've earlier mentioned here, with the exception that the second intervention arm did not receive the mentoring aspect, where educators were followed up on a 3 monthly basis for 1 year. And we evaluated the performance of students in terms of knowledge and skills at the end of their training. And what we saw is that providing this support to these training colleges, students within the intervention colleges performed much better in terms of knowledge and skills compared to the counterparts in the control institutions. And these findings triggered a detailed review of the curriculum within the country, which had previously been reviewed in 2013. So a gap already here in terms of when our curriculum are they reviewed. So following this study, we reviewed the curriculum for the nursing and midwifery training within the country, and we had a cluster randomized controlled trial which assessed the effectiveness of this curriculum delivered by trained and mentored educators on the quality of education and also the student performance in Kenya. So we first conducted knowledge checks and also the baseline checks for the clinic for the skills, teaching skills of these educators at baseline. Then we provided a training to both sets of educators within the intervention and the control colleges. And then for those in the intervention colleges, we supported them with a 3-monthly mentoring, focusing on the teaching pedagogy and also the EMOC skills that we expect them to be competent in. And at 6 months and 12 months of this intervention, we also had focus group discussions to get the views of these educators on how best they were able to implement these. And then we also had we assessed students at the end of this intervention within the 2 study arms, just to test whether having this intervention, does it translate to good performance among the students? And the findings here show that if you look at the knowledge and the confidence to teach EMOC, the intervention was able to improve the knowledge and confidence of these educators immediately after the training. And when you look at the observed practical teaching skills for these educators, as expected at baseline, there were no differences. But when you look at the end line, the educators from the intervention colleges had a statistically higher performance compared to their counterparts in the control colleges. And the same thing is now being reflected here when we assess students from the two study arms. We see that students from the intervention colleges, in terms of knowledge and the 3 select skills that we assessed them on, students within the intervention colleges had higher performance scores compared to their counterparts within the control colleges. However, it will be important for you to also note that if you look like, for instance, this skill here, newborn resuscitation, which is a key skill that helps to save most of the newborns after delivery, it will be important for you to note that in all, whether in the intervention or the control college, the skills are really so low that there was no group that had at least a 50% mark, which means there are still gaps. Even when these students are about to graduate, there are still gaps in the type of providers we are going to have, and therefore the need for added support. However, this study provides evidence that a system of mentoring, when implemented within these institutions, is effective to improving the quality of teachers and also the performance of the students. And we followed this by conducting a nested qualitative study just to understand the experiences and the views of the educators, the mentors, and also some of the students whom we assessed to understand how they felt about implementing this updated curriculum. Now, for the educators, they felt integrating this emergency obstetrics and newborn care within the curriculum was a very relevant update for them, because students are now able to practice these things within the clinical environment, feeling more empowered and not just observers in terms of provision of care. And educators also appraised this as a very good opportunity for them, which gave them an opportunity as a continuous professional development opportunity for their skills. And this improved greatly in terms of their teaching skills and also the clinical support given to the students. However, usual suspects when it comes to the barriers or the challenges that were experienced, as one of the low-middle income countries, the population of students compared to the volume of educators that we have, there is a complete mismatch where we have so many students compared to the number of educators, and that gives us a challenge in terms of the quality of supervision we expect these teachers to get. And then so many challenges around the aspect of clinical support these students receive within the units, as we expect them to, by the time they are graduating, we expect them to be better in terms of the skills to provide for the mothers and newborns. But they receive very little support by the teachers because of that challenge where the educators are so few. And even within the hospital side, we do not have clinical preceptors to support these students within that side. And this places a challenge in terms of the type of educators and the type of quality providers we are going to get after graduation. Happy to report that these findings have been the catalyst to the EMOC training now being offered in the country, both in the universities and also at the diploma level. Now, these findings, educators showed that it was a good opportunity for them to improve their skills. And we went ahead to conduct a systematic review to just find out, do we have these midwifery educator systems to help educators improve their skills and knowledge within the low-middle income countries? And it was surprising that we do not have much evidence around this area. This is a very underinvested area where there are no formal CPD programs that we were able to find that have been managed by the nursing and midwifery councils within the low-middle income countries. Now, the available evidence, at least for those programs that were there, most of them have used the twinning approach, where we have our big brothers from the developed countries supporting our counterparts within the developing countries. Now, a key challenge that we noted on this is the issue of sustainability. Once the big brother leaves, then they leave with the intervention. What remains for us? And that made calls for a need for people within the low-income countries to design sustainable regulator-approved programs that are able to improve the quality of midwifery education. And these findings led to the development of a midwifery educator CPD program to improve the quality of teaching and clinical skills. And I'm happy that one of the co-educators we worked on this platform is here, Terry Kana. Thank you so much. And for this program that we developed, this was a blended midwifery educator CPD program, which had a self-directed online component and a practical skills component within select centers where educators went to improve their teaching skills and also their EMOC skills. And being the first within the African region, we tested the feasibility of this package using the mixed methods design in Kenya and Nigeria. These are two countries. You know that Nigeria is one of the countries with the highest number of maternal mortalities in Africa, and therefore it was important for us to test these within a setup that has one of the highest mortalities. And so we evaluated these in terms of the knowledge, pre-knowledge, and also the skills for the educators, rated their confidence on a number of skills, and they did direct observations of their teaching skills just to be sure what they were doing. Interesting results here. Most of the educators, all these educators rated this program as having been very relevant to their practice and their needs, as it was a timely and there was demand for this. And they were very satisfied with the content. And overall, in terms of the quantitative findings, we saw that there was a significant improvement in terms of the knowledge, confidence, and the skills of these educators after going through the program. And overall, this program was effective and feasible to be implemented within the low, middle-income countries. And key to note for this program is that after testing this program has now been accredited by the Nursing Council of Kenya as a program for CPD for midwifery educators in the country. And this program also has the global access where over 51,000 educators around the globe, including the high-income countries, have been able to access the self-directed online component on the WCA platform. From almost 60 countries have been able to complete this. And since this is LSTM 125 celebrations, I'm also happy to report that this specific program here was awarded as the best contribution of the year for LSTM EMOC unit in May this year as the best contribution of the year. This was the last study, and we see a lot of implications from this work that we've done around practice, policy, and also research. In terms of practice, we see the need for supporting these midwifery graduates as they leave these training institutions to go to start practicing, and they need mentoring from the qualified senior staffs, and the need for reviewing of the curriculum and also investments around the staffs. There is need for mandatory CPD for educators. Once they have these opportunities, then they are able to improve their skills so that they can deliver the quality teaching to the students. And we also need investments in the preceptors so that we can improve the quality of our students within the clinical environment. In terms of further research, we've provided evidence that these interventions are relevant and they are working. We've eaten the whole bull, but we still have the tail that we need to finish here. I'm looking at this important aspect. These interventions, they need to be scaled within the other low middle-income countries, but we need to understand the cost. What is the cost of having these interventions implemented in other settings? Then we also need to have at least another follow-up on the effectiveness of these interventions, at least on the change in behavior for the educators and the overall health outcomes of these interventions. I would like to sincerely acknowledge the Liverpool School of Tropical Medicine for the opportunity you gave me for the PhD, Professor Lalo, and my excellent supervisors, led by the immaculate Professor Charles Ame here. and all the donors who funded my study, the Johnson & Johnson, UNFP, and UKAID, and the stakeholders within the country. In case of any questions, we are available. You can reach us through either me or Professor Charles Ame. Thank you so much.
Thank you so much, Duncan. I think now we are at the, we've had so much information, but probably not enough time to take questions. So if we can pack the questions till the end, so we can power through the next two speakers before our keynote. So it gives us great pleasure to invite, our next two speakers to speak on the treatment and control of malaria in pregnancy and childbirth. The first speaker will be Dr. Kohi, who is a pediatric infectious disease specialist with primary research interest in malaria and global child health. Our next speaker, whom most of you will know, is Professor Tekule, who is a clinical epidemiologist who has researched extensively malaria in pregnancy. So they have between them to share so much knowledge within 10 minutes. No pressure there. You're welcome.
These are not my slides. There's a raised hand addressing this in the back. So FICO and I are going to give you all a whirlwind tour of LSTM's contributions to successes and failures in drug-based malaria prevention and control in pregnancy and childhood, I hope. Shall I just click through? Yes, here we go. All right, so I'm going to fast forward in the life course. No, these are the older versions of slides that were uploaded this morning. They were replaced in the full session slide deck. Yes. All right. Here we go. I think. Again, now the pointer's not working. All right, we're going to just go through all the technical challenges. Here we go. All right, so I'm going to fast forward in the life course to focus on malaria in school-age children. Fortunately, death is a relatively rare outcome in school-age children. However, malaria is the leading cause of death in 5 to 14-year-olds in sub-Saharan Africa. Additionally, school-age children have frequent episodes of uncomplicated clinical malaria, which leads to health system burden, economic strain on families, and undermines the education of this age group. Additionally, we in Malawi and others have shown that parasite prevalence peaks in school-age children, with in some cases more than 50% of well-appearing children sitting in class trying to learn with detectable parasites in their blood. These chronic infections lead to anemia and decreased cognitive function. We've also shown that school-age children are the primary reservoirs of human to mosquito transmission, perpetuating infections in their communities. So what can we do to decrease this burden? Chemoprevention, which is the routine administration of a full course of anti-malarial drugs to both clear existing infections and provide a period of prophylaxis against new infections, is a promising intervention in this space, but what I'm going to talk about would likely also be achieved through effective vaccination in this age group or monoclonal antibodies in this age group. More than 30 years of clinical trials has really demonstrated the individual level health impact of this intervention. Chemoprevention decreases clinical malaria, it decreases prevalence of infection, and it decreases anemia in this age group. However, where we need more data is whether chemoprevention or decreasing the burden of malaria in this age group contributes to community-level transmission reduction, and whether it improves cognitive function, learning, and ultimately education. So in moving this intervention from research to policy and then to program, as I said, there have been many trials. I'm highlighting 3 here, conducted by Sarah Stedke and colleagues in Uganda and myself with colleagues in Malawi. In 2021, together, we published a systematic review and meta-analysis of preventive treatment in school-age children, and these results underpinned the inclusion for the first time of intermittent preventive treatment, so chemoprevention, in school-age children in WHO's malaria control guidelines. This intervention could benefit more than 200 million school-age children in sub-Saharan Africa. However, since this policy was implemented, only one country has been given minimal funding to do limited implementation of this intervention. To try to unlock progress from policy to program, this year we received some seed funding from Open Philanthropy. In discussions with stakeholders, we've identified both barriers and facilitators in this process, and I'll highlight here one primary barrier which has come up throughout the symposium, which is limited funding. So our current malaria funding barely covers core interventions, and there's a concern that if we stretch this funding to target school-age children, we will leave uncovered vulnerable children under 5 who are at higher risk of severe disease and mortality. This is where I think our need for more information on the community-level transmission benefit is critical, because it could be that if by targeting school-age children, we reduce community-level transmission, that may allow our existing interventions to be more effective. This limited malaria funding also leads us to opportunities, which is we need to capitalize on the impact of this intervention on education. And we need to engage the education sector not only on figuring out how to implement this intervention, but figuring out how to measure impact on education and use metrics that are meaningful in the education sector. To this end, I'm working together with Eve Worrell to develop cost-benefit frameworks that would incorporate both health outcomes and education outcomes to really understand the potential for broader economic impact of these interventions. Additionally, within the school, we have the opportunity to work beyond our disease-specific silos to develop integrated school health interventions, which would lead to cost efficiencies of delivery and also potentially utilize schools as platforms to increase healthcare access, moving us towards universal healthcare access. So ultimately, we think that this intervention could stand to improve not only health-related sustainable development goals, but also improve education and decrease poverty. Over to FICO.
Hello, everyone. Well, in the spirit of powering through the presentations, I will try and summarize 20 years of research in the next 3 minutes and start with one success story and one failure, just to keep the balance, about malaria and pregnancy. And so I probably don't have to tell you that malaria is bad for you, and particularly in pregnancy, and particularly in the first trimester of pregnancy. And the big challenge, of course, is that drugs that are available in the general population, so in children, adults, including in women of childbearing age, are often contraindicated in pregnancy, and particularly in the first trimester for understandable reasons. And often that is related to the fact that when new drugs come on the market, which are typically more effective than existing interventions, there is no safety data in the first trimester. Because there is no safety data, they are not recommended in the first trimester. Because they're not recommended in the first trimester, there's no safety data being accrued. And you end up in this catch-22. And we're particularly worried about first trimester malaria because this is a very vulnerable period in pregnancy, and malaria, even asymptomatic malaria in the first trimester, can result in pregnancy loss, so spontaneous miscarriage and stillbirth, or in vulnerable newborns, so children born either preterm or small for gestational age, or with low birth weight. And because these new drugs are contraindicated in the first trimester, pregnant women are often treated with older less effective drugs. And that is particularly the case for malaria and pregnancy, where women up till 2022 were treated with a 7-day regimen of quinine. And I don't know how many of you have ever tasted quinine or antimalarials, but it's a very bitter drug. Has to be taken 3 times a day for 7 days in a row. And as you can appreciate, adherence to a 7-day regimen is very low. And because of the low adherence, the treatment effectiveness is low and therefore results in a high risk of treatment failure. Yet, the general population was moving on to a new generation of antimalarials, artemisinin-based combination therapy, or ACTs, which were widely used and are now first line in almost all countries in the world. These women, the pregnant women, were not benefiting from this information, yet many women of childbearing age were treated with ACTs and either did not know they were pregnant or did not report an early pregnancy. And as you can appreciate, pregnancy testing is often not done in resource-poor settings. So many women of childbearing age were actually treated with these drugs that were contraindicated in the first trimester. And this led us, when we were part of the Malaria Consortium, to set up pregnancy exposure registries and follow women that were inadvertently treated with these antimalarials prospectively, look at pregnancy outcome, and compare that to women that were treated with the standard of care at that moment, quinine, and looked at pregnancy outcomes. And these studies were very surprising, and Stephanie Delicourt from our group led a meta-analysis that combined data from many different research groups working all over the world, including in Thailand and several countries in Africa, and showed that the women that were inadvertently treated with this newer generation of antimalarials had 42% less pregnancy loss or congenital malformations than women that were treated with quinine. And this resulted in an update of the WHO recommendation for the treatment of malaria in the first trimester, switching from quinine to artemether-lumefantrine. And that's now being implemented globally in almost all countries in Africa. And so that is, as you can see here, a big thumbs up, results that have changed WHO policy. And we're now working, and again, this is research led by Stephanie Delacour in collaboration with Camry, looking at inadvertent exposures of the newer generation of antimalarials, dihydroartemisinin piperacin, pyronara artesunate, to see whether these women, when you follow them prospectively, have similar findings as we had with artemether-lumefantrine to expand the arsenal of drugs that can be considered in the first trimester. We are also very happy to share that MMV, I don't know if there's still a representative here of MMV, Christina was here on the first day, are very supportive of co-funding or co-sponsoring a first-in-its-kind pregnancy trial of treating pregnant women with these newer antimalarials, comparing that to the new standard of care of artemether-lumefantrine in the first trimester. And that study is likely to start in a few months' time. That was the success story. Now, just to keep the balance, we have also conducted a series of trials looking at the prevention of malaria and pregnancy. And WHO is recommending IPTP, intermittent preventive treatment, in pregnancy with an antimalarial called sulfadoxine-pyrimethamine, or better known to most of you as Fansidar. Very effective if taken compliantly, but the main challenge is resistance of the parasite, the malaria parasite, to sulfadoxine-pyrimethamine, widespread in East and Southern Africa. And we've been looking for the last 15 years at alternatives to IPT with SP, with sulfadoxine-pyrimethamine, either looking at alternative strategies, intermittent screening and treatment, where you screen pregnant women with a rapid diagnostic test at every monthly antenatal clinic visit, and then treat them if they're test positive with artemether-lumefantrine or DHA piperacin, or looking at alternative drugs that could replace SP as part of IPTP. And these studies, and I think we're talking about a budget of $40 to $50 million globally across the other partners, have been very disappointing. All drugs that we have tested, amodiaquine, chloroquine, mefloquine, have been shown to be badly tolerated, to be to give to pregnant women as part of prevention. The only drug that looked promising was dihydroartemisinin piperacin, very effective anti-malarial, very effective, much more effective than sulfadoxine pyrimethamine at preventing malaria. And we're talking about sort of 80 to 90% greater reductions in malaria with the newer generation of antimalarials. But to our surprise, they did not result in better pregnancy outcomes. And that, in the end, is what matters. So the children born to mothers in the SP arm were born to mothers who had much more malaria during pregnancy, but they were born with higher birth weights. And there's now an hypothesis that SP may have very important malaria-independent benefits on child growth that have been neglected in the past. So this series of trials has not moved the needle, so to speak, has not resulted in a change in WHO policy. And unfortunately, we're still using SP probably for the foreseeable future, even though there is high-grade resistance to SP in East and Southern Africa. So very disappointing. What next? I see Adrian Hills here today. We're very interested in looking in the R21 malaria vaccines for malaria and pregnancy, and potentially, once we can afford it, monoclonal antibodies. I had another success story, but we're well out of time. So I'll end it here with a big thank you slides, which shows the collaborators that are employed by the LSTM. But there, of course, there's a list of another 100 collaborators across all these studies, and at least 13 funders that we would like to thank. So thank you very much.